Good morning and welcome to Heart Center Grand Rounds. I'm Dipan Shah, Chief of the Division of Cardiovascular Imaging here. And very pleased to have with us today a guest who's here in person in the studio with us. And before I introduce today's speakers, just a couple of housekeeping announcements. First off, I want to also introduce Dr. Amar Telmasani, who's our Advanced Imaging Chief Fellow, who's also here with us in the studio. And for those of you that are tuning in via the web, if you have any questions, and hopefully we'll have some time for questions at the end with our speaker, please go to pollev.com, enter the keyword DeBakey, and type in your question. Or you can go via text at 37607, text the keyword DeBakey, and then you can type in your question. And I think we'll have some time for questions at the end. So without further ado, let me introduce today's speaker, Dr. Amit Patel, who's here with us from the University of Virginia. And Amit just recently moved, so this is probably his first trip outside of Virginia since he moved to Virginia. So I'm glad we're able to get him to entice him to come here to Houston. So Amit really needs no introduction. He's a renowned multi-modality imager, I think with expertise especially in cardiac MRI and cardiac CT. Amit is currently a professor of medicine at UVA, as well as the director of non-invasive cardiac imaging and the director of cardiac MRI and cardiac CT. Amit's background really is in imaging evaluation of inflammatory, infiltrative, and ischemic heart disease. He's very well published. He's also on the board of trustees for the Society of Cardiac Magnetic Resonance, and he's been a peer reviewer as well as an author in numerous cardiology and radiology journals. And I think, most importantly, I think is that I think Amit's going to bring to us a perspective not just from one single imaging modality, but rather from multiple imaging modalities as to how we approach the evaluation of patients with cardiac sarcoidosis, both from the standpoint of identification of sarcoid, as well as detection, or as well as assessment of risk stratification. So Amit, I want to thank you very much for making the trip here from Virginia to Houston, and I'm very glad to have you here. So I'm going to turn the floor over to you.
Well, great, Dr. Telmasani, Dr. Shah, thank you so much for the kind introduction. It's a real privilege and honor to be here today. So here are my disclosures. The slides are not forwarding over there. Okay. I'm not sure which slides are being seen, but I'm going to start with the case of a 38-year-old male with increasing burden of palpitations. You should be seeing an EKG here. Maybe I'll do it this way. Okay, I'm just going to go by what's up there. So you should be seeing an EKG here, which shows the patient's having runs of non-sustained ventricular tachycardia. On the right-hand side, you can see his echocardiogram, which shows severe LV dysfunction. And you can look at the contractility pattern here, and the apex is functioning better than the base, suggesting that this is likely a non-ischemic etiology, and that is consistent with his age. Now here, because of the concern for non-ischemic cardiomyopathy, he had was referred for cardiac MRI, and you can see he has late gadolinium enhancement here in the septum, along the lateral wall, also here in the anteroseptum, inferolateral wall, just extensively along the anterior wall, inferior wall, just throughout the ventricle here. And this is highly suspicious for the diagnosis of cardiac sarcoidosis, just based on the pattern of late gadolinium enhancement. So he was referred for a cardiac PET scan, and the first thing to note is that he does have lymphadenopathy that's taking up FDG here. And then you can see he's got really extensive FDG uptake through the myocardium, left ventricular, and then also focal patches in the right ventricle there. And clinically, this is really a strong indication of the diagnosis of cardiac sarcoidosis. Now, usually you want to try to get some kind of tissue validation. And so the patient was referred for an endomyocardial biopsy and lymph node biopsy, which were both negative. Nonetheless, given the strong clinical scenario and suspicion for cardiac sarcoidosis, he was empirically started on prednisone. He then underwent a repeat endomyocardial biopsy, this time guided by electroanatomical voltage mapping in the EP lab, and this only showed fibrosis. And not to give up, he finally had a VATS procedure, or a video-assisted thoracoscopy, and a repeat lymph node biopsy, which finally revealed non-necrotizing granulomas, and he received an official final diagnosis of cardiac sarcoidosis at that time. Here's his baseline images. You can see these are the same images I just showed you, and here's the MRI image of his LV function and RV function. You can see that they are both severely reduced. Now, after 5 months of immunosuppression, if you look here, you can see the lake enhancement is significantly less all throughout the ventricle, and on the FDG PET image, there's near resolution of the FDG uptake throughout the heart here. So a very strong response to immunosuppression. And you can see here his ejection fraction is considerably higher following immunosuppressive therapy. So during follow-up, the patient, despite the immunosuppressive therapy, had ongoing ventricular tachycardia, which was ultimately followed by an ablation procedure. And at that time, he finally also agreed to getting an ICD implanted. He had been reluctant to do so prior to this. So what is sarcoidosis? Well, it's a rare multisystemic granulomatous inflammatory disorder. The etiology of sarcoidosis is not well defined, but what we know is that it is a relentless immune response that persists even after the antigen has cleared. And at autopsy, about 25% of the sarcoidosis patients have cardiac involvement, and this is why, as cardiac imagers and cardiologists, we're highly interested in this disorder. You can see here it can involve the brain, the lymph nodes, the lung, the liver, inflammatory responses on the skin, the eyes, the spleen, and the joints. So it's truly a multisystemic disorder. Now, there is a broad differential diagnosis you have to consider when you're thinking about sarcoidosis. There's a variety of infectious agents, occupational and environmental exposures, and even various neoplasms and other autoimmune disorders that are all on the differential diagnosis. It is the great mimicker, referred to as a great mimicker at times. Now, one of the challenging things about sarcoidosis is that the treatment is definitely not our run-of-the-mill heart failure therapies. As you can see, in addition to prednisone, there are a variety of medications that we're using to treat sarcoidosis, cardiac sarcoidosis. Most commonly, perhaps methotrexate, azathioprine, mycophenolate, increasingly infliximab, and even now there's a study looking at IL-1 agents, interleukin-1 agents. Now, the clinical features of cardiac sarcoidosis often represent symptoms such as dizziness and lightheadedness, syncope, edema, a cough, shortness of breath, and palpitations and arrhythmia. And the type of symptoms and the actual presentation very much depends on the extent of disease involvement. Oftentimes you can see small patches of involvement in the ventricle which are completely silent and not evident clinically. As the disease process involves an increasing amount of the interventricular septum, as in this cartoon here, you can start to develop more heart block, and left bundle branch blocks, right bundle branch blocks, that sort of thing. And as the disease process goes from being from unifocal involvement to a multifocal involvement, and there's an increasing amount of fibrosis that happens, you can start to see more ventricular tachycardia. And as the disease process spreads further, you start to see heart failure in addition to the heart block and the ventricular tachycardia that we commonly know about. Now, there is sarcoidosis is an inflammatory disorder, which means that the way that the disease progresses is from initial inflammation, where you might just see a thickening, in this case of the septum, And then as the inflammation leads to more destruction of the myocardium and fibrosis starts to form, you can see focal areas of myocardial thinning, famously in the interventricular septum, and even aneurysms at the base of the ventricle here. And then as the fibrosis really progresses further and the neurohormonal system kicks in, you can start to develop a dilated end-stage cardiomyopathy. So what is the natural history of cardiac sarcoidosis? Well, I would say, given that it typically occurs in relatively younger patients, the prognosis is poor. There's a 29% in this particular study mortality after just 6 years of median follow-up time. The presentation of heart failure at the time of presentation is particularly associated with a poor prognosis, with 50% 10-year survival. Now, if you look at these Kaplan-Meier curves and kind of look at the 1-year mark, you can see that there is roughly a 15% mortality irrespective of the initial ejection fraction. However, as time passes and you get further along, you can see the underlying ejection fraction does start to separate the prognosis. However, to the point where maybe here at 5 years there's a 40% mortality if your EF is less than 35%. But even if your EF is mild to moderately reduced or even preserved, frankly, you can see there is still a considerable mortality associated in these patients. Now, the treatment, as I mentioned already, is fairly unconventional for a cardiologist. The treatment extensively utilizes immunosuppression, and then there is the use of ICD is expanded beyond just a severely reduced ejection fraction. Here's a kind of registry that we were involved with when I was in Chicago with 112 patients who all had a diagnosis of cardiac sarcoidosis and an ICD implanted. And what you can see is that a third of the patients received appropriate therapy for their ventricular arrhythmia, and many of these were VT storm, as you can see here. And this translates really into a primary prevention rate of 11% and a secondary prevention rate of 20%, which is consistent with the contemporary ICD trials that we all are familiar with. Now, importantly, 12% of the patients do receive inappropriate shocks and therapy, and I'll explain what that's due to here briefly. Some covariates that are associated with the arrhythmia are ejection fraction less than 55%, RV dysfunction, and heart failure symptoms. So here are kind of more data looking at kind of the risk of just a sarcoidosis patient in general, not someone who has cardiac sarcoidosis, but just any sarcoidosis. And you can see the risk of heart failure in this orangish color is greater is probably 2 or 3 times higher than in the general background patient population. Similarly, you can see the risk of atrial fibrillation in sarcoidosis patients is greater than in the general population. And it is this atrial fibrillation and atrial flutter that's likely driving much of the inappropriate ICD shocks that these patients can receive. Now, there is very little, if any, randomized controlled trial data telling us how to treat these patients. Generally, steroids are used. Here is a kind of a very small study that helps support the use of steroids in these patients. And here you can see in patients with cardiac sarcoidosis who had less than a 50% ejection fraction, those patients who had early initiation of their corticosteroids, you can see a significant improvement in their ejection fraction following therapy. However, in those patients who had the delayed initiation of corticosteroids, you can see there's actually an ongoing decrease or no difference in ejection fraction at follow-up. And this may be related to the fact that perhaps the inflammation is converting into fibrosis, and we've missed our opportunity to kind of deal with the inciting inflammatory process. Now, making the diagnosis of cardiac sarcoidosis is quite challenging. As you can see in this slide, a slam dunk diagnosis occurs if you have an endomyocardial biopsy, and I'm going to show some data about the problem with that. Or you can have extra cardiac tissue biopsy plus 2 major or 1 major and 2 minor criteria. And I'll just go over briefly. The major criteria are things like high degree AV block, fatal ventricular arrhythmias, a basal thinning in the interventricular septum, like the example I showed you. I'll show you more data on that as well, or the presence of kind of a ventricular aneurysm or thinning or regional thickening of the myocardium. Another criteria is just the presence of LV dysfunction. And then there's kind of details from advanced imaging such as gallium scintigraphy or FDG PET uptake, and then late gadolinium enhancement, which you'll see more of as well. You can make the diagnosis without any tissue at all. However, in that situation, you really do need a strong suggestion a clinical suggestion of pulmonary or ophthalmologic sarcoidosis, and this includes, lymphadenopathy, biomarkers, and other findings, and then also the 2 major or some minor criteria. It's particularly difficult to make a diagnosis of isolated cardiac sarcoidosis because you need to actually have 4 of the 5 major criteria to meet to make a diagnosis of isolated cardiac sarcoidosis. So what are the goals of imaging in cardiac sarcoidosis? Well, first, we'd like to diagnose the disease. And we would like to do that perhaps in sarcoidosis patients who don't even have symptoms. This would be essentially screening. Of course, we would also like to identify it in patients who do have cardiac symptoms. Any patient with unexplained arrhythmia may be a good candidate to look for cardiac sarcoidosis, or any patient with unexplained heart failure. We would like to determine the need for immunosuppressive agents, and then also perhaps determine the immune response to these agents. We'd like to know the risk of arrhythmia and determine also the risk of downstream heart failure. And here you can see there are multiple ways we can go about making the diagnosis. Endomyocardial biopsy has a very low sensitivity, as does electrocardiography and echocardiography. Because of the low sensitivity of these kind of more standard things that we would do, imaging such as cardiac MRI and cardiac PET have really found a mainstream role in the evaluation and management of these patients. So what are some of the echocardiographic findings of cardiac sarcoidosis? 1, left ventricular dysfunction, right ventricular dysfunction, regional wall motion abnormalities, diastolic dysfunction, abnormal myocardial strain, valvular disease, pericardial effusions. Now, these and pulmonary hypertension, these are all associated with cardiac sarcoidosis. However, they are all, as you can imagine, fairly non-specific. More specific would be basal or focal thinning of the anterior septum, especially when it occurs in a non-coronary distribution. The presence of a basal inferior LV aneurysm or regional thickening is something else that should put sarcoidosis on your radar. Here's just an example of that basal thinning that you can see right here, kind of near the area of the membranous septum. And interestingly, when you do have this basal thinning, you can see in this study, these Kaplan-Meier curves, those patients have considerably worse prognosis than patients with cardiac sarcoidosis who don't have that. What does cardiac sarcoidosis look like on kind of CMR and PET? And here's a really nice study by Chit and Shenoy where they actually did a really interesting literature search where they found images that were published throughout the literature, autopsy images, and then from that created kind of a cartoon of what an MRI or really here, what they were focused on MRI, what an MRI would look like. And so here are just several examples of end-stage cardiac sarcoidosis. You can see it's multifocal and fairly extensive damage. One kind of consistent pattern is you can see how the abnormality starts off in the septum here. It doesn't really involve the endocardium, and then it hooks over into the right ventricle. You can see that in all of these kind of examples. And then here you can see kind of a triangular patch of late gadolinium enhancement also down here, where it involves the infraseptum, the inferior segment, and then also the RV. And these are referred to as colloquially as the hook sign or the triangle sign. And these are just some real life examples of kind of the hook sign, and then maybe it's more like a trapezoid sign here, but same idea of a triangle sign and the corresponding PET image. And I guess the way to think about this is that the damage, the myocardial damage, is not respecting any predictable anatomical layers of the heart. It's, you know, the fibers, you have layers in endocardium, mid-myocardium, and epicardium, and here it's just involves whatever it wants to involve. And now one kind of thing to highlight is that all of these examples are autopsy examples, or these are end-stage examples of cardiac sarcoidosis. But of course, there's a much earlier stage, and here you can see just a focal patch of late gadolinium enhancement and the corresponding FDG uptake. So really, it could be a wide range of possibilities that you might see. This is a nice study by Yuchi Han and colleagues when she was at Penn, again looking at this triangle sign down here, where it's involving the multiple layers of the LV and the RV. And you can see a very, at least in this cohort, very high specificity for the diagnosis of cardiac sarcoidosis. Now, it's not all so straightforward. I showed you some great examples, but making the MRI diagnosis of cardiac sarcoidosis can actually be quite challenging. Here's data, I believe, from the Ottawa group showing the inter-observer variability on quantifying the burden of late gadolinium enhancement in patients of cardiac sarcoidosis. And you can see the two readers did not agree with each other very much. And the R-squared value here is just 0.55. So you know, there is a lot of education and work and room for improvement when it comes to detecting and diagnosing cardiac sarcoidosis. Now, cardiac PET is also commonly utilized or to evaluate cardiac sarcoidosis, and I think there are kind of some basic patterns that we should recognize. And PET, in this case of PET, you really are looking at both perfusion and FDG uptake to help you fully understand what's going on. So here on the left are two cases where the perfusion is totally normal. There's no FDG PET uptake here, and then there's diffuse FDG uptake here. And these are all normal because, of course, there's normal perfusion and no inflammation here. And in this case, it's just a failure to suppress normal myocardial metabolism. And this can be a trap, and so you have to be really careful not to misdiagnose that as cardiac sarcoid. On the other hand, here you can see a perfusion defect here, and then you can see corresponding FDG uptake. This is referred to as the mismatch pattern. This is a strong indication for the diagnosis of cardiac sarcoidosis. You can have situations of normal perfusion and focal FDG uptake, as shown here. Now, it's important to remember that this could either represent early disease, or this may just also be failure to suppress normal myocardium or some other mechanism of FDG uptake. You can also have a pattern of perfusion defect in the absence of FDG uptake, and this would be felt to be due to myocardial scarring or fibrosis without active inflammation. And you can, of course, have a mixture where you have both scar and inflammation as well. Now, one of the key things to getting a high-quality cardiac PET results is really what I would say is zero-carb diet prep for patients undergoing this study. We oftentimes will have 1 or 2 days of zero carbohydrates for the patient to prepare for their PET scan, and then starting at 6 p.m. the evening before their study, make them NPO to really try to suppress normal myocardial physiology. And we found that to be very effective. Others additively will use heparin and other agents to really try to suppress normal physiologic uptake of the FDG. Now, There is a differential diagnosis to the uptake of FDG. We often get trapped to think that, oh, there's FDG uptake, this must be cardiac sarcoidosis. But I think it's important to remember that FDG uptake can be due to inflammation, due to ischemia, or to infection. And I already discussed kind of this idea of FDG uptake in the absence of normal perfusion. This can be a fairly nonspecific finding that we must interpret with caution. There are other causes of inflammation, just any other type of myocarditis, and a variety of rheumatologic conditions that can have cardiac involvement. Of course, ischemia and hibernating, or here as I put it, hypernating myocardium or stunned myocardium. It is important to make sure that you've ruled out coronary disease in the territory proximal to any area of FDG uptake. And then finally, if you're not careful, just attenuation correction from ICD leads and such can cause an increase in signal, leading you to misdiagnose cardiac sarcoidosis. Cardiac MRI has been used to detect myocardial injury as a screening tool. Here are one of the earlier studies published by A.Patel from the Duke group, where they took 80 patients with known extracardiac sarcoidosis and performed MRI on them irrespective of what their symptoms and such were. And what they found was that when they just looked at the standard clinical criteria for the diagnosis of cardiac sarcoidosis, they were able to identify 10 patients that they thought had cardiac sarcoidosis. However, when they did cardiac MRI, actually 20 patients had, or twice as many patients actually had cardiac sarcoidosis. And clinically this was important because during follow-up, 5 patients actually died. And the clinical criteria used at that time only identified 2 of those patients, whereas the cardiac MRI identified 4 of the 5 patients. Since then, there have been much larger screening studies utilizing cardiac MRI. Here's a study of over 300 patients with biopsy-proven extracardiac sarcoidosis who underwent screening with symptoms, EKG, Holter, transthoracic echo, and cardiac MRI. And what they found was that all of the kind of easy standard things that we do all have a very low sensitivity for the diagnosis of cardiac sarcoidosis. Now, some of them have higher specificity, like certain findings on transthoracic echo, but cardiac MRI really performed extremely well. Now, you have to be careful when interpreting this because the diagnostic criteria that were used actually include cardiac MRI as part of it. So it's a little bit deceptive to say that cardiac MRI has a sensitivity and specificity of nearly 100%. Now, the detection of late gadolinium enhancement was seen in 30% of these patients, so it's not a rare occurrence. However, with follow-up, it was shown that there was a 25% event rate in these patients who had late gadolinium enhancement. So it's not a benign finding. And here you can see their outcomes. Those patients who had no late gadolinium enhancement had an extremely good prognosis, whereas those who did have late gadolinium enhancement did considerably worse. So with these data, there's some discrepancy on kind of the societal recommendations for screening for cardiac sarcoidosis. The Heart Rhythm Society recommends all patients get a cardiac history, an EKG, and an echocardiogram. And then if any of them are abnormal, they should go on to kind of an imaging with either cardiac MRI or cardiac PET. The American Thoracic Society actually took a different approach based on their review of the literature, and they actually do not recommend screening with even transthoracic echocardiogram. Just symptoms is really the primary method that they recommend for screening. However, they do at least recognize that doing an echo or a Holter monitor is a fairly low-risk procedure, and so you could talk to the patient and decide if you want to do it. So just very discordant recommendations, and frankly, neither of the societies recommended using screening cardiac MRI despite the data that I just showed. And perhaps it's because of the cost of these techniques. Here's just an example of some hospital charges at at an institution where a cardiac PET might would be charged, not paid for, that's not what's reimbursed, but what would be charged for over $8,000 plus the spec cost. On the other hand, a cardiac MRI also not with a low charge of almost $5,000. Now the reimbursement can be a lot lower, so the cost to society and a payer may only be $400 or $500 for an MRI. It's not clear what the Medicare reimbursement is more variable for PET imaging. Now these costs highlight that there is really a need to find a more available and cheaper way of diagnosing cardiac sarcoidosis. And here, these are data from our lab where we kind of started to look at strain imaging on echo, and we looked at a small cohort of patients with biopsy-proven extracardiac sarcoidosis who all had a preserved ejection fraction, and used global longitudinal strain and looked at the ability of abnormalities in global longitudinal strain to detect the presence of underlying late gadolinium enhancement. And what we found was that, first of all, patients who had late gadolinium enhancement had a much lower strain value than those patients who did not have late gadolinium enhancement. And in this particular cohort, we found a cutoff value of minus 17% to actually have a very high sensitivity and specificity for detecting late gadolinium enhancement or cardiac sarcoidosis. And this is just an example of an AUC. Of course, this is too good to be true, but for what it's worth, you can see those patients who had a global longitudinal strain better than minus 17% had a good prognosis, and those lower had more events. These data were also similar findings seen by Dr. Ori and colleagues. Here another small study, but this time they were looking at regional strain rather than global strain. And again, what they found was quite interesting. When looking at regional strain, they found that circumferential strain actually was strongly predictive of the presence of late gadolinium enhancement. And this may be due to the fact that longitudinal strain typically involves is looking at the disease process in the subendocardial layer, whereas the circumferential strain is looking at more the mid-wall fibers, and which is where the sarcoid more often is found. Now, these are other data just published recently, kind of looking at the use of strain to predict future cardiac involvement. And here I'll just focus on the graph on the right. And the bar graph on the very left is patients without sarcoidosis, and you can see their left ventricular global longitudinal strain is about minus 19%. However, patients with extracardiac sarcoidosis without a diagnosis of cardiac involvement have a slightly lower strain value, and then as they have known cardiac sarcoidosis, it's further lower, and if they had isolated cardiac sarcoidosis, even lower. Now, what's really interesting is if you take this group of patients who have extracardiac sarcoidosis and you divide them up with those who develop cardiac sarcoidosis in the future versus those who do not, you can see that patients who had kind of a higher baseline longitudinal strain value, they did not really progress to developing cardiac sarcoidosis in the future. And so all of these data suggest that we may be able to really use echo, more advanced echo approaches like strain to try to identify those patients who are at risk of developing cardiac sarcoidosis. Now, every single sarcoidosis patient likely has had a CT scan at some point. And there is a huge burden in these patients who have to undergo, oftentimes get a CT scan, then they get an echo, then they get an MRI, and then they get a PET scan. And so we do need to make some effort to help out our patients and reduce the burden of diagnostic testing. And these are some interesting data comparing delayed enhancement CT against late gadolinium enhancement cardiac MRI. And showing that it may well be possible to detect using a CT those patients who have cardiac involvement. More work is needed, but this is certainly promising data. Now, it's easy to make a decision about a patient who has cardiac sarcoidosis that has a severely reduced ejection fraction and whether they need a defibrillator or not. And that's just standard for any disease process. However, in cardiac sarcoidosis, there's data that suggests that patients who have intermediate reduction in ejection fraction may also benefit from a defibrillator. Here's data from Dr. Crawford and colleagues in 50 patients, all of whom had an EF between 35 and 50% undergoing cardiac MRI. And what they found was that 2/3 of the patients had late gadolinium enhancement, and that was very sensitive for identifying those individuals who were at risk of death in VT. Now, if they had also late gadolinium enhancement involving the right ventricle, or if they had multifocal late gadolinium enhancement or a burden of late gadolinium enhancement more than 6%, those patients were also at higher risk of kind of more specific for developing ventricular tachycardia and poor outcomes in the future. Now, for those of us who do a lot of imaging in sarcoidosis patients, you know that most patients have normal ejection fraction, yet we detect a fair number of these individuals with late gadolinium enhancement. And indeed, we were able to show that in one of our cohorts that nearly 20% of patients with normal ejection fraction or preserved ejection fraction have late gadolinium enhancement. And this was only half of these would have been identified through standard clinical criteria. And so this begs the question, well, does it matter? If you have late gadolinium enhancement and a normal ejection fraction, is this associated with increased outcomes? And this chart here, oops, there we go. This chart here was expansion of the initial cohort of over 200 patients with follow-up of a few years. We can see that those patients who had late gadolinium enhancement, actually 25% of them died or had sustained ventricular tachycardia. This is a 20-fold increase in their risk as compared to if they didn't have late gadolinium enhancement. And this translates into an annualized event rate of 5%. So alternatively, of patients who did not have LGE, only 1% of patients died or had sustained ventricular tachycardia. This risk is further modulated by the burden of late gadolinium enhancement. So at least in our cohort, they had a greater than 5% burden of late gadolinium enhancement or associated RV dysfunction. Again, these were kind of added risk to just the presence of late gadolinium enhancement. And here's just a Kaplan-Meier curve showing kind of this significant separation of the curves. Here's a meta-analysis done by Michael Salerno in his group a number of years ago, kind of really looking at several papers that are published on late gadolinium enhancement. And you can see if you have an ejection fraction greater than 50%, the presence of late gadolinium enhancement has a significant odds ratio of still being associated with ventricular tachycardia or death. When you have a reduced ejection fraction to begin with, it's less clear. You can see the confidence interval crosses over 0, and it just may be that there are fewer, these studies are smaller in size and don't have the power to show the independent value of late gadolinium enhancement in these patients when they have a reduced ejection fraction. Now, I've shown you multiple slides or alluded to the fact that the right ventricle is important. In these patients, there are multiple mechanisms by which the right ventricle can be involved. It could be due to secondary effects from lung disease and secondary pulmonary hypertension, or it can be from pulmonary arterial hypertension, or it can be due to the direct involvement of sarcoidosis of the right ventricular myocardium. And sure enough, those patients who have isolated RV dysfunction, they're at increased risk of death, but it's really from all-cause death, perhaps more likely to die from complications of lung disease or pulmonary arterial hypertension, versus those patients that had right ventricular late gadolinium enhancement. They were more likely to die from sudden cardiac death or have significant ventricular arrhythmias. Now, I think diagnosing cardiac sarcoidosis when a patient has a known diagnosis of sarcoidosis is considerably easier than when they don't have a known diagnosis of sarcoidosis. And so there are certain cohorts of patients where you really want to have a heightened suspicion for the diagnosis. Here's an example, a study done by our group. These are all patients who presented with unexplained ventricular tachycardia, who had coronary artery disease excluded, other known causes of VT excluded. They all underwent cardiac MRI and cardiac PET imaging. And the first finding was that 2/3 of the patients had late gadolinium enhancement, and within that cohort, about 10% of them also had FDG uptake. So this kind of gives you an idea that the number needed to image, let's say, is not so high to make the diagnosis of cardiac sarcoidosis in patients presenting with unexplained ventricular tachycardia. Now, this is just a small retrospective cohort, but it does give you a signal that this may be an area that you need to look further into. Now, one of the challenges is oftentimes patients with cardiac who have VT get a defibrillator placed prior to ever having any diagnostic imaging done. And historically, we used to think, well, you've got a defibrillator, you can no longer get a cardiac MRI. And I think that's essentially been debunked now as a major problem for doing cardiac MRI. What is or used to be a challenge is getting high quality images when you have a defibrillator, because the device itself causes a huge artifact, as you can see by the asterisk here, which looks just like late gadolinium enhancement if you're not careful. However, the use of newer late gadolinium enhancement techniques, referred to often as the wideband technique, can actually erase this artifact, as you can see here, and allow you to notice the actual late gadolinium enhancement that's present. And so, if you are going to be imaging patients with a defibrillator, you need to have, of course, safety protocols in place, but then you really should be using this wideband technique to do your late gadolinium enhancement. Now, cardiac PET also offers a significant prognostic value in these patients. These are, when you have a PET scan, essentially you can divide them into 3 groups of those with normal perfusion and metabolism, who do very well. Those who have both abnormal perfusion and metabolism do worse. And then if you have just one or the other abnormality, you have more of an intermediate probability. Now, I think this starts to beg the question, well, what's more important? Is it the inflammation? Is it the scar tissue? And I think this is a really nice study done by Paco Bravo and his group, where they actually looked at a group of patients who had both MRI and cardiac PET done. And what they found was that if both you had no late gadolinium enhancement and you had no FDG uptake, your prognosis was excellent. However, if you had late gadolinium enhancement, it didn't matter if your FDG was positive or negative. Both groups did equally poorly. So this suggests that really the prognosis is being driven by the scarring in the myocardium rather than the inflammation. And these findings have been validated here by Dr. Gawani and colleagues in another cohort. Now, kind of looking at it at more of a mechanistic level here, Dr. Muser and colleagues looked at kind of performed comprehensive electroanatomical mapping, and then looked at areas that had normal electrograms and abnormal electrograms. And what they found was that areas that had abnormal electrograms were far more likely to have scar than areas that did not have abnormal electrograms. On the other hand, those areas that had abnormal electrograms actually had less inflammation than areas that had normal electrograms. And this was verified in kind of 2 different ways of assessing the metabolic, the inflammatory activity. So again, kind of suggesting that it is the scar that's driving the ventricular arrhythmias, not the inflammation. Here, kind of another interesting study by Dr. Carr and colleagues, looking at patients' outcomes after catheter ablation. And here they took the sarcoidosis patients, divided them into 2 groups. Those patients who were in the scar group, you can see a very high complete success rate following catheter ablation. However, in the inflammatory group, you can see the rate of complete success was considerably less. And looking at it another way, looking at VT-free survival following the ablation procedure, you can see those in the SCAR group had a very high VT-free survival, whereas those in the inflammatory group had a significant recurrence of their ventricular tachycardia. Now, it's based on these data, or these data support the Heart Rhythm Society guidelines, which really talk about patients who should get a defibrillator. And you can see down here, as you get when you have patients, you can see patients who don't have late gadolinium enhancement, an ICD is not recommended, especially if their ejection fraction is preserved. If they do have late gadolinium enhancement, these may be a group of patients that may benefit from ICD. Now, in addition to just detecting scar and inflammation, we are really, for treatment purposes, very interested in looking at the amount of inflammation that's there. And so here are a couple examples of patients who have FDG uptake, and then following steroids, you can see improvement of resolution of the FDG uptake. And in this particular patient, the prednisone was stopped. On the other hand, here you can see the patient had extensive FDG uptake, and then it improved to just a focal amount down here. The ejection fraction improved, but because there was still ongoing inflammation, prednisone was continued. These are data from Ron Blankstein's group showing the inverse relationship between the improvement in active inflammation and the change in ejection fraction. So again, highlighting the concept that if you treat the inflammation, you may help improve the ejection fraction and then theoretically prevent heart failure down the road. Now, it is, although FDG uptake is considered the reference standard for detecting active inflammation, I think it is important to remember that you can detect inflammation by cardiac MRI as well. Here you can see an example of a patient with late gadolinium enhancement with increased T2 signal here. The problem is when you just qualitatively look at these images, the sensitivity and specificity are quite poor. However, what this group did was they actually normalized the myocardial T2 signal to the spleen, and they found they identified anything over a ratio of 0.58 was considered abnormal. And when they used this kind of more quantitative approach to T2 weighted imaging, they actually had a very high sensitivity for detecting abnormal FDG uptake on PET. So now, kind of develop, speaking towards improving patient burden, maybe we don't have to refer every single patient who has late gadolinium enhancement for a cardiac PET. We can perhaps use T2 weighted imaging, and if we do it quantitatively, we don't have to refer those patients for PET and save patients the hassle. But more research is needed. Now, I think they also kind of got a little controversial here because they created a different reference standard where it was clinically active cardiac sarcoidosis based on VT or whatever, and kind of compared the accuracy of T2 stir imaging against PET imaging. And what you can see is the T2 stir had high sensitivity, lower specificity, whereas PET actually had a modest sensitivity and specificity for this. And when you look at the overall accuracy, the two are actually somewhat similar. A lot more research is needed to really know what's going on. More recently, as many of you know, with MRI, we do a lot of highly quantitative mapping techniques, T1 mapping and T2 mapping. And here data from Dr. Cruiser and Dr. Puntman showing really that patients with active cardiac sarcoidosis have higher T2 values. Here showing that they have higher T1 and T2 values as well. And then if they get treated with immunosuppression, the T1 and T2 values decrease. So again, hints that we might be able to use MRI as biomarker. As I talked to earlier, cardiac MRI and cardiac PET are less available, and hospital charges can be quite high. And so identifying echocardiographic ways of tracking disease may be important and beneficial. So it may be that we can define the disease with MRI or PET and then use echo to follow treatment response once we've correlated everything. And these data from Cleveland Clinic, looking at 84 patients and showing that strain abnormalities, here you can see a strain abnormality in the septum, are associated with active inflammation, shown down here, and this has prognostic value as well. And so this, you can conceptually imagine a situation where, okay, patient gets an echo, patient gets a PET scan, you know what the regional strain looks like at baseline in relationship to that actual PET scan done at that same time. Then you can just follow improvement in strain over time if you can do it kind of robustly. This is, again, a concept that would need to be verified. Now, more recently, there have been the development of new technologies, these hybrid PET-CMR scanners that can do both PET and MRI at the exact same time. And what you find is start to see some really interesting things. Here you can see in patient with active cardiac sarcoidosis, you see the late gadolinium enhancement here correlating exactly with the FDG area. And here's another example of late gadolinium here matching exactly the FDG area, also in these other two examples. On the other hand, you can see patients with late gadolinium enhancement and no FDG uptake at all, and this would be inactive cardiac sarcoidosis, or you could see the absence of both, and this would be patients who don't have cardiac sarcoid. And then here's an example of failed myocardial suppression, and in this particular study, nearly a quarter of the subjects actually had this issue, and so having the absence of late gadolinium enhancement may help you recognize this a little bit better. They also find this tricky group where you have FDG uptake in the absence of late gadolinium enhancement. And as I mentioned earlier, this is a non-specific finding. This could be due to ischemia, or this could be due to failed myocardial suppression of metabolism, or this could be early cardiac sarcoidosis. But I think you have to interpret this group of patients with caution. I don't think you can assume for certainty that that is active cardiac sarcoidosis. And of course, now you can also apply the mapping sequences in these hybrid units. A lot of work is needed, but again, just very promising technology developments that may benefit our sarcoidosis patients. And so I'd like to close with two slides. Here is just the ASNC guidelines for sarcoidosis. If you suspect cardiac sarcoidosis, cardiac MRI is preferred. If it's abnormal, you would move on to FDG imaging to determine if there's active inflammation or just scar to help you decide the treatment plan. And if it's normal, the MRI, you can just clinically follow them up, and maybe on rare circumstances need to cross over to FDG PET imaging. And then with that, I think sarcoidosis is really a disease that's best suited for multimodality imaging, and I think it's really important that we as imagers and people taking care of patients with sarcoidosis are not hammers looking at nails. We really need to look at all our options and find out what's the best test for the right patient at the right time. And with that, I'd like to say thank you, and it's a real privilege to present to y'all.
Great. Amit, that was fantastic, really a fantastic presentation. I think you did a very nice job of touching on all the different imaging modalities that we have and how they overlap with each other. We've got several questions from the audience as well. And before we get to those, I'll ask you one question. I mean, to me, it seems like there's kind of two pathways of patients that we see. Those that have a known diagnosis of extracardiac sarcoid, where there I think our imaging is really trying to see is there cardiac involvement or not. But then this other group where, some of them have some of the classic symptoms, VT or heart failure or something else, and then we're trying to, based on imaging findings, sometimes infer that there may be sarcoid. And then a third group almost, which is they're coming in for something, we find some findings on imaging, you find some LGE or something, and I know, the question becomes is, you want to be sensitive to pick up a disease like this, but at the same time, how do you balance that without being overly sensitive and driving a bunch of downstream additional testing? And along that line, I think I saw that the case you showed highlighted how you hunt for really a diagnosis, right? By looking for tissue diagnosis, or in essence, having kind of do you have a multidisciplinary approach where if you can't make a diagnosis by tissue, you have a pulmonologist and a ophthalmologist that has an interest in this? I mean, so maybe share with us how you approach these patients, not so much the ones that are known sarcoid, but rather the ones that are kind of the other two groups.
Yeah, so you're right. The known sarcoid is a lot easier because they have the disease, and then it's unlikely that they have multiple diseases, though we see that. These patients who are coming in with ventricular tachycardia, sustained VT, VF, sudden cardiac arrest, and you've really, they are all getting extensive evaluation. You've ruled out everything you can think of. I think it really is a good idea in those patients to go the extra mile and look for sarcoid kind of aggressively. And I think an MRI first approach can be very powerful in those patients. And I would, once you see the MRI abnormality, I would not feel bad at all about going forward with the PET scan, because they are presenting with some serious symptoms. The others, when they're presenting with heart failure and they're just getting a general cardiac MRI to understand the etiology of heart failure, I think that is a lot trickier. These patients, you see a little bit of late gadolinium enhancement, and you don't want to fall in the trap of just ordering a PET scan now, because that is going to probably be fairly low yield unless they're having the heart block or some other things. I tend to look at the images. I do when I see late gadolinium enhancement. I'm looking for the extracardiac findings, like the lymph nodes on the MRI, or look through the chart for heart block and ventricular arrhythmias and that sort of thing. But then I am increasingly looking at the T2 imaging carefully, and if I'm not seeing any hint of T2 uptake associated with the area of LGE, then I might not in my report put forward the diagnosis of cardiac sarcoidosis. Whereas if I see that there is T2 there and it's matching kind of the area of LGE, I will kind of push that forward in my report. And so that's where I kind of, as the person reporting it, tries to be reasonable for the referring doctor.
Yeah, try to help them navigate.
Yeah, exactly.
Yep.
I think your other question was related to, remind me.
Well, so I don't want to hog up all the questions, so I'm going to take some of the ones from the audience as well. So there was one question from the audience was, I guess, in essence, it was something to the effect of, how sensitive is cardiac MRI for identifying cardiac sarcoid involvement? And so can you have, if you have a normal LGE, can there still be cardiac sarcoid? And when would you think about, is there a role for then doing PET in those cases, and what the yield is?
Yeah, I would say if you have no LGE, I think, and you are going to do a PET scan, I would say please have a very high clinical suspicion for cardiac involvement, because how you utilize the downstream information, first of all, we know those patients who have normal LGE, their prognosis is excellent. And that's been consistently shown over and over. Those patients, and if you do find FDG uptake in that scenario, it's a little bit of a non-specific finding. So you may find yourself in a trap. Of course, it's possible that you could have cardiac sarcoidosis in the absence of late gadolinium enhancement. I mean, but I would say I would categorize it as a rare finding, not a common finding.
Okay. Another question from the audience from Iowa Heart Center is, what are your thoughts on high sensitivity troponin as a marker of active inflammation?
I don't think there's a huge amount of data on that, but just kind of inherently that makes some sense to me, being that we are detecting such small levels of troponin. But I'd like to see some more data to really kind of support that issue. It may end up being a little bit non-specific as well, because you know, a lot of things can cause elevations in your troponin. But it's an interesting idea.
And then another question from the audience here. I think it's really geared around kind of this EP-guided biopsy. Maybe if you want to share with us how you're approaching that and when you're using that.
Yeah, I think some of the electrophysiologists that I've worked with have been doing kind of full cardiac mapping, both endocardially and epicardially, and they'd identify areas of low voltage and then target that as the source of biopsy. The data suggests that the yield is definitely higher when you do that. However, I would say the case I presented that was done, and it was a non-specific finding. So I think the issue will be that, at least in my eyes, your voltage will be lower, irrespective of if it is inflammation or scar. And so, but I think a lot of people are advocating for that.
Yes, so Dr. Patel, like amazing presentation. So I have two questions. So first, for the CT delayed enhancement, is that done with gadolinium?
Yeah, no, it's done with iodine. You inject, I don't know, some more contrast than you normally would, and then you wait 5 minutes and you acquire your images there. However, I think they're applying tricks, right? So first of all, it's going to work better if you have a dual source, a dual energy system, or you acquire images using a much lower kV to bring out that iodine signal. And then I think beyond that, people are acquiring multiple of these low dose images and then fusing them together to build your signal to noise.
I see.
And try to get those images. But I think I think the data is promising, but there's a lot of technical, in my opinion, a lot of technical development that still needs to happen.
Perfect. And the second part is, when do you stop prednisone after like a normal study? And would you do surveillance with the cardiac MRI?
Yeah, so I still do move to, once I've kind of decide there's inflammation there and I'm treating the patients with steroids, I'm really going with PET at that point. I'm not really doing repetitive MRI imaging so much. And so for my practice, at one point, we were using like 60 milligrams of prednisone and hitting them really hard, but we found that maybe using a lower dose, like 30 milligrams, again, data is all over the place here, and it's but using a lower dose like 30 milligrams, I tend to re-image at 3 months with PET and see if there's complete resolution or partial resolution to help me decide where I'm going. I may add on a non-steroid steroid-sparing agent like methotrexate, and then and as I taper down my prednisone, and as I taper down, I may image again 3 months later to see how the activity is. I'm following patient symptoms and other things as well, of course.
Perfect. Yeah.
And then if it recurs, I will bump back prednisone up and might use one of these other agents like tumor necrosis factor or some agent or something.
Thanks.
Great. Well, Amit, that was a fantastic presentation and a great discussion. I want to thank the audience also for all the questions. I know we're a few minutes over time, but I thought it was very important to bring out some of those questions. Again, thank you very much for making the trip over here, and also congratulations on your move to UVA.
Great, thank you.
All right, thank you. And we'll see you all again back here next week.